Hello, class. I'm just going to go over this last week of medications that you should hopefully look over before we get together on Tuesday for our last class of the 8 weeks. Hard to believe we're at week 7. As far as your Olson assignment, just again review Chapter 11, some of the important information regarding flow rates and dosage rates for intravenous medications. Be sure to pay attention to many of the alert and important information that's out in the margins of that chapter, as well as all the previous chapters when you go ahead and start to study for the final. So there's really not too much information that's new. Just like I said, review some of that reading for that chapter, as well as continue to do some of the medications at the end of the chapter. You all seem to be doing very well with dimensional analysis, so I really don't think that's an issue. Very few people missed any of the dosage calculations on the test, so people are doing very well with that. Probably what I'm going to go over today now is just kind of review the medications. You're going to be learning about BPH, benign prostate hypertrophy, as well as hyperplasia of possibly the bladder and some of the urinary structures, as well as medications that you would see prescribed for patients that might have urinary tract infections. I do have within the modules uploaded the various chapters from your Adams book. They're very lengthy and very, very detailed, but it will give you a little bit of the anatomy and physiology, as well as the pathophysiology when you relate these medications to why they're being given for these patients that might have urinary issues. The first thing I just want to kind of talk about, so it makes sense when I kind of explain some of the medications, is the meds do help to minimize a lot of the urinary obstructions and prevent some of the complications that go with patients that aren't able to avoid completely. And that means to, completely empty the bladder. And anytime the urine remains stasis within the bladder wall, it's a excellent media for bacteria to grow. And this is where some of our patients, especially when they become somewhat dehydrated, aren't drinking enough fluids, they lose that capability of the bladder being rinsed, especially within the inner walls of that bladder, and that's why many people may experience urinary tract infections. The meds that you may see prescribed for someone that has BPH, it doesn't reverse or it doesn't cure BPH. Many times BPH is present, and some gentlemen may be completely asymptomatic. If they do have mild symptoms, they might be prescribed, certain medications, but not all BPH is progressive. A lot of management of BPH is not only through medications, but a lot of what a person drinks to encourage and teach patients to avoid alcohol, caffeine, and even some of the drugs that they may be on that may worsen BPH. Encourage people to restrict fluids at bedtime, and usually if the diagnosis has been made, they tell that particular patient to come back and see their healthcare provider and reevaluate them about every 6 to 12 months to see if the BPH has become worse. If it has, drugs may be given. Okay, so that's kind of how it works. Usually meds may be used to treat either mild to moderate BPH, and many times if these do not work very well, alternative may be that the person needs some kind of surgery. But remember, the medications do not cure the disease. These medications will have to be taken by the person for the rest of their life, or until surgery may have to happen. If they stop taking the meds, the prostate gets large again, and they continue with the same problems with urinary retention. And a lot of times what may happen with men is the urinary tract infections that they may get would be more of like a prostatitis, okay? So usually 25% of men age 60 or over will have both increased blood pressure as well as BPH. And so sometimes these medications can help both of those problems, okay? So I'm just going to talk a little bit about the medications, and when we get together on Tuesday, we can kind of go over them again and see if you have any questions. I'll probably have another worksheet for you, and that'll be pretty much what our class will consist of, okay? So let me go on and begin to talk a little bit about the medications. The first med that I'm going to talk about is bethenacol. It's also known as uricoline. It's on page 153 in your Adams book. It's therapeutically used for urinary retention, and pharmacologically it's a cholinergic agonist, or muscarinic agonist, direct acting. And the reason it's prescribed for someone is to treat urinary retention, and also for adynamic ileus and gastric atony. It really basically acts directly with the muscarinic receptors to cause body responses typical of parasympathetic stimulation. And this has been around a long time. It was approved way back in 1948. And it helps to stimulate smooth muscle contraction. And within the urinary tract, how it works is it relaxes the sphincters and causes the detressor muscle of the bladder to contract, thus causing someone to be able to urinate or void better. It is treated for non-obstructive urinary retention, atony of the bladder, and of course adynamic ileus or gastric atony, okay? Some of the adverse reactions are increased salivation, abdominal cramping, sweating, flushing, and blurred vision. Remember, it interacts directly with the muscarinic receptors to cause body responses very typical of parasympathetic stimulation. So that's why you get some of these adverse reactions, okay? It can also cause orthostatic hypotension, complete heart plaque, and even acute bronchospasms. So you would be very, very cautious on using this on a patient maybe that has a history of asthma. Some of the contraindications, because of the way this drug acts, is it can be aggravated by increased contractions of the GI tract, such as a suspected bowel obstruction, recent GI surgery, an active ulcer, or any type of inflammatory disease. Recent bladder surgery, even people with cystitis, people with COPD and asthma, just like I said, and even somebody that already has a slow heart rate. Even have a history of MI and hyperthyroidism. You would not use it, obviously, with peritonitis, epilepsy, or any kind of Parkinson's disease. So that's the drug called bethenacol or uricoline. So please, I'd like you to put a star by this if you're jotting down some of this information as you listen to me. You have some of the parasympathetic type reactions that may be adverse for your patient, such as I said before: increased salivation, abdominal cramping, blurred vision, nausea and vomiting, and even orthostatic hypotension. Be very cautious to use with someone that already has bradycardia on board. You would be very extremely cautious and probably bring it to the attention of the healthcare provider if you saw any type of history pertaining to the patient having a urinary obstruction, recent urinary surgery, cystitis, asthma, COPD, MI, or bradycardia, or hypotension. So those particular conditions, we would not see benethicol being used. So I think with this type of a medication, it's very, very important to know your patient's medical history and kind of assess their abdominal, bowel, and bladder functions. Definitely looking at renal and hepatic function, and sometimes these patients develop some type of sensitivity to light, so make sure that they are provided eye comfort. And remember, the autonomic nervous system does regulate the functions of our internal organs, such as the heart, stomach, and intestines. So because of the impact it has on the parasympathetic nervous system, that would cause the patient's heart rate to drop. So in case of an overdose, you may want to administer sub-Q atropine. That will help block that parasympathetic response and hopefully increase heart rate. So that's bethenacol, or also uricoline. Treats urinary retention. Okay, the next medication that I want to talk about is finasteride, or Proscar. It's on page 1221 in your Adams book. It's also a therapeutically used for BPH. It's an anti-androgen, a 5-alpha reductase inhibitor. Okay, this is a medication that helps to treat BPH, a benign prostatic hypertrophy or hyperplasia. And what it actually does, it will help shrink the enlarged prostate. It's also used for propecia, which is hair loss, and also mild to moderate hirsutism in hairy women, in females. And sometimes we see some of these situations where women grow hair where they shouldn't grow hair due to some endocrine changes. And even has been known to possibly help against prostate cancer. However, the manufacturer doesn't really state this and promote this particular indication for the medication. This is a medication that, after even a couple doses, it takes a while or takes several months for that prostate to start to shrink. There are, of course, few side effects, but the ones that may occur can, be very concerning to the male patient, particularly when it's sexual dysfunction or even gynecomastia, where men start to have enlarged breast. If you are taking finasteride or Proscar, you would not be able to donate blood because obviously the medication would be in the bloodstream, and it would be very concerning if that donated blood was given to a woman who was pregnant, because it could cause problems with her unborn male child. This has been around since 1992, and it does inhibit the mechanism of testosterone. That's why it acts on shrinking the prostate. It's been also used with doxycycline or Cardura, to help also with, blood pressure control as well. It has been marketed as a way in which propecia can be helped with new hair regrowth. Again, the main reason finasteride is usually prescribed is for BPH. Okay, it again works by promoting regression of the prostate epithelial tissues and decreases mechanical obstruction of the urethra. And as I said, the side effects, think about for a male, shrinking the prostate, sexual dysfunction is a big one, such as impotence, diminished libido, and the decreased amount of ejaculatory substance, and again, gynecomastia, reduced sperm production, and sometimes impaired fertility. So those are pretty much the more concerning side effects. Sometimes these men who take this medication may also feel very lethargic, don't have a lot of energy, and just complain of a lot of physical weakness. Usually given for men over 55 who have increased risk for prostate cancer. Do not use, obviously, for a woman, because like I said, it could be given for women with hirsutism, where they have a lot of hair where they shouldn't have hair. But if the woman is pregnant or lactating, or even a female or children, it would not be given. If you have a female pharmacist who is pregnant, it would be advised not to handle this medication, and anybody who administers this medication are strongly encouraged to wear gloves, as it can be absorbed through skin and damage male baby. So that's why you would really not even want a female pharmacist to wear to even be around this medication. Anticholinergics may decrease the effects of Proscar, and use with testosterone decreases the effects of both meds, the finasteride as well as the testosterone. Some of these herbs like saw palmetto potentiates the effect of Proscar, and if someone takes an overdose of this medication, there is really no treatment for overdose. Assess medical history, assess sexual history. Maybe a certain person is trying to conceive, so it'd be good to look at the history behind the husband as well as the wife. Assess urinary history. Do not abruptly stop, may cause rebound hypertension and tachycardia. And that's why a lot of times, because these men are on this medication, they may take that saw palmetto, but unfortunately, because they're trying to boost their testosterone levels and increase their sex drive, but when they take it, it potentiates the effect of Proscar, and they may be more prone to some of the serious side effects that I just, finished discussing about. I think that's about all. To get the maximum effect from finasteride, the person has to be on it for at least 3 to 6 months, and the duration of action is about 2 weeks. Okay. Other than that, remember, avoid handling the med if they're if they're pregnant or anything, because it can be absorbed through the skin. Okay. And assess renal and hepatic impairment, because you want to use this med with extreme caution. Okay. Now I'm just going to talk about some of the antibiotics that may be prescribed for someone that has a UTI or some other type of localized infection. The first one I'm going to talk about is a ciprofloxacin, or Cipro. It's an antibacterial. Pharmacologically, it's a bacterial DNA replication inhibitor, and it's a fluoroquinolone. Okay. to treat a lot of gram-positive, gram-negative bacteria. It affects the, DNA of that particular bacteria, and that's how it's able to destroy the bacteria and relieve the infection that a person is experiencing. Cipro or ciprofloxacin is a second generation. Can give up to PO 250 milligrams to 750 milligrams. You can take up to a maximum of 1,500 milligrams a day. Okay. Cipro's, let's see if, I just wanted to see if I had a time. Cipro's been around for a while. It is used to treat urinary tract infections, even some of your sinusitis, even pneumonia, skin infections, bone and joint infections, even some infectious diarrhea, and even some eye infections. It's a broad-spectrum antibiotic, most effective, like I said, against gram-negative organisms, such as the familiar ones, Klebsiella, Staphylococcus, Shigella, Salmonella, Neisseria, Serratia. It can also be used to treat acute otitis media and acute otitis external in kids over 6 months old. Okay. Of course, with any of these antibiotics, they cause a lot of GI upset, diarrhea, nausea, and vomiting, most common. That's why it's encouraged to take these antibiotics with food to decrease a lot of the side effects. Should not take them, though, with antacids or mineral supplements such as calcium or iron, because it'll decrease the drug absorption of the medication. Some things like phototoxicity, headache, dizziness, or some of the things you might see. Rare but can occur is a pseudomembranous colitis can occur. And the black box warning is that Cipro can cause tendinitis and tendon rupture, muscle weakness. Should not be used in pregnant women or with CNS disorders or renal patients. Use cautiously with patients who are taking Coumadin, because it can result in some increased bleeding. And even with some of your medications that your asthmatics take, such as your xanthines, like aminophylline, caffeine, theophylline, theobromine, can show hepatic metabolism of these drugs. The overdose is just treated symptomatically, whatever the patient is manifesting. Other than that, Cipro was produced in very, very high quantities, I should say, quite a while ago when they were concerned that maybe a terrorist attack of anthrax was going to occur. So this would be the drug that would be used to treat an anthrax terrorist attack, where they kind of brought in that bacteria and hopefully wanted to see, countries and populations infected with that. Cipro would be the one that we would, definitely treat that with. Sometimes some of these other problems like brucellosis from dairy products is another reason why you might give Cipro. It's been around since 1990. And as I said before, 1987. It's been around for quite a while, almost 30 years, over 30 years. Okay. Other than that, just be very cautious when someone is on Cipro. If they would happen to have, like I said, be on those xanthines or like a theophylline, it's going to increase their theophylline levels by 15 or 30%. That's extremely important to know, because someone could develop some theophylline toxicity, okay, and cause them problems with their respiratory system, okay. So the next one is Bactrim or Septra, sulfamethoxazole, which is also an antibacterial medication. Pharmacologically, it's a folic acid inhibitor or sulfonamide. Again, given for UTIs, can also be given for prophylactis P. Giravici pneumonia, and also Shigella infections of small bowel travelers, diarrhea due to E. coli. Can be also given for acute exacerbation of chronic bronchitis due to streptococcus or pneumonia or Haemophilus influenza. All right. Again, inhibitors of bacterial metabolism of folic acid. Each inhibits a different enzyme in the metabolic pathway, creating a synergistic combination selective toward bacterial folate metabolism. Again, you know, sometimes GI disturbances. The one thing you want to watch for is the Stevens-Johnson syndrome, epidural necrolysis, even granulocytosis, on some of those things like aplastic anemia that affect some of the red blood cell development. Should not be used with sulfites, sulfonamides, thiazide diuretics. Again, used cautiously with anticoagulants, potassium-sparing diuretics such as aldactone, and potassium supplements. Should not use if folate deficiency anemia, renal or hepatic impairments, hyperkalemia, and patients with age. Be very cautious using Bactrim or Septra. This has been a long, long time in the making. I remember when I was a kid seeing Bactrim and Septra ordered for like a urinary tract infection. So it's been around a long, long time. UTI prophylactically can be used for complicated and uncomplicated UTIs, depends on the severity. Can be given either PO or IV, and again, watch for the serious adverse action of Stevens-Johnson syndrome rash. And it's really important to prevent crystalluria to the kidneys, so it's encouraged to drink a lot of fluids when you're on your Bactrim and Septra. Can cause also photosensitivity, so people that are on it should avoid direct sunlight, okay? Again, I think we've talked about everything as far as contraindications. So that is your sulfamethoxazole or your Bactrim or your Septra, which is on page 839 in your Adams book, okay? And then, let's see, this might be, oh, another thing too with the Bactrim, if overdose of bone marrow depression present in high dose therapy, you may give 5 to 15 milligrams of leucovorin, should be given daily, okay? And that medication I was talking about is leucovorin, Leucovorin, and all it is a drug a chemotherapy protective drug. And I know this isn't on your list, but sometimes I myself like to know what these meds do, and if it's something that to be given for an overdose for bone marrow depression, it would help treat anemia caused by a lack of folic acid. It is also used in supportive care of patients with colon cancer and to treat overdoses of certain medications, and that's what it would be used for in this case with Bactrim or Septra. Okay, just a little added information. Okay, and then the next group of medications, or the last one we're going to talk about, is your nitrofurantoin macrocrystals, or macrobid, or macrodantin. It's on page 841 in your Adams book. It's also an antibacterial. Pharmacologically, it's a urinary tract antiseptic to treat acute cystitis, which is a fancy term for infection of the bladder, and also prophylactically for a recurrent UTI. And again, how it works is it attacks those bacterial ribosomal proteins and inhibits protein synthesis, aerobic energy metabolism. And the one thing you want to be cautious about is pulmonary toxicity. And this does not always manifest immediately. It may not occur for months to years later, such as a pneumonitis or a persistent cough, or even pulmonary fibrosis. It can cause hepatotoxicity, and use cautiously in renal patients and pregnant women, and in kids less than 1 month old. It should not be used in someone who is experiencing oliguria, which means a very little amount of urine. Usually oliguria is defined as somebody not voiding, probably voiding less than 400 milliliters in a 24-hour period, and definitely not with someone who is experiencing anuria, which means no urine at all, as this drug needs to work to in order for the drug to work correctly, and it needs to have urine to work. Should not be given with antacids containing magnesium, just cause decreased absorption, and sometimes if you give them with other antibiotics, may result in antagonism and decreased drug effect. Okay, so the really key thing with this drug is, with your macrobid and your macrodantin, is to make sure that the patients are putting out enough urine. And in order to do that, you want to also make sure that the patient has adequate fluid intake. Okay, and again, always watching your patient's lab values, knowing their medical history, any allergies, and watching lab work, especially potassium levels, renal and liver function test. And just watch frequency and color and consistency of stools. I think that's pretty much it with medications. Let me see if I have anything else on those. The kidneys are obviously important with many medications, but with your urinary antiseptics, kidney concentrates, the drug reaches therapeutic levels in the kidney tubules, then to the bladder. As I said before, nitrofurantoin is available in 3 formulations: the microcrystalline form, which is furantoin, microdantin, and then macrobid. Again, they all inhibit protein synthesis, and again, the big adverse reaction is that interstitial pneumonitis that may not be manifested or exhibited immediately. Obviously not to give the med with patients with kidney problems, pulmonary diseases, and of course don't give it with antacids because of the decreased absorption. I hope this helps a lot. we'll go over some things on Tuesday. See if you have any questions. Maybe we'll do a couple case studies. Maybe we'll play a little game too, just to kind of refresh your memory about these meds. But that pretty much concludes all the medications for week 7. And then week 8 on Tuesday we'll have our final. And so that'll conclude our Nursing 124 course for 8A. So I hope you guys are all doing good. I'm sure you're getting excited that it's the end of the 8A. So if you have any questions, let me know. I'll answer your email as quickly as I can. But I look forward to seeing you all on Tuesday. Have a wonderful weekend and a great Monday, and take care of yourself, okay? Hang in there, guys. We're almost done. Bye-bye.